Okay, so in the interest of time, let's get the show on the road, as they say. It's truly a privilege. That's an often used word, but happens to be real on this particular occasion, to welcome Dr. Hopkins. And it's not very often we have invite neurosurgeons from other centers to come and give us a talk. But Dr. Hopkins is really not just a neurosurgeon. He's been involved in the interventional world for many years. I got to know him really because of a conference that he ran, and it was called the Global Complications Conference. Now, I think the name has changed to be a little bit more politically correct, but it was a multidisciplinary conference that he would invite the leadership in cardiology, radiology, neuroradiology, vascular surgery, and they'd all get together, and the charge actually was, you can come and you got to present. Everybody had to present, and everybody had to present a real disaster, not of your partner's making, of your making. And so it was and you signed a confidentiality agreement, and the whole idea was, there are, despite the best of intentions and despite being in the hands of good people, bad things happen, and there's an opportunity to learn from one another from it. And so I've told many people it's the most educational conference of the year that I would end up going to, because it was very humbling to see really good people have very bad things happen to their patients. And not only did it come from the clinicians, but there was also industry would be there, and their engineers would present, device failures and how they would analyze those failure modes. And so Dr. Hopkins is not just active in the neurosurgical world. I think he's highly regarded across the whole cardiovascular specialties, particularly because of his interest in failure analysis, and he gave us a great talk about that last time. In addition to that, he recently stepped down as the chair of neurosurgery in Buffalo, and it's one of the most highly published neurosurgery departments basically in the country. But he was also instrumental in pulling together an institute really that focused on cardiovascular disease with particular emphasis on cerebrovascular disease, in which again he kind of brought all the different specialties together, and they would also invite industry to come along and participate in it. And so he's been very innovative both in failure analysis but also on multidisciplinary collaboration. And I think that that's one thing in the Heart and Vascular Center here we've been extremely proud of, is that as we have built these different departments, is increasingly it's how we connect together. How do we build centers basically of excellence where patients can come in, be seen by the cardiologists, be seen by the surgeons, be seen by anesthesiologists, basically all in one setting, and then with that team approach. Well, Dr. Hopkins really was on the forefront of doing that. I think if I read the entire dossier basically on you, and Nick would be here all day. So with that, I'm going to ask him to come and tell us a little bit about how we can learn from him in building a cerebrovascular center of excellence. And you're really going to hear from one of the world's leaders and somebody who's actually accomplished a lot of things he's talking about. So thanks again for coming. We really appreciate it.
Thanks, Alan. Thank you very much. It's really a great pleasure to be here. Particularly, it's a great pleasure to be amongst cardiologists and vascular surgeons and radiologists, because that's been the focus of my whole career, is try to extend neuro, which was my basic training, into all the other disciplines. And I'll show you a little bit about why I feel that way. So basically, disclosures, there really aren't any significant disclosures that impact this, except perhaps Toshiba. They've been our research partner for years, but I don't have any personal benefit from them. And so what I think I want to share with you today is a bit of a personal journey that I've had over the last little more than a decade, when a family approached me, the Jacobs family from Buffalo. Larry Jacobs was my close friend and colleague in neurology. He was a stroke neurologist to start with, but along the way, by serendipity, he discovered beta interferon, working with some scientists over at Roswell Park. And that discovery led Larry to become an international hero in multiple sclerosis, because for so many years it's been the standard of care for relapsing multiple sclerosis. So Larry got cancer in 2001 and died a year later. And I was walking into the dean's office with him when we stepped off a curb, and he said, "Jesus, I got a Lhermitte's going on here. I feel tingling up and down." And it turned out that he had mets everywhere, including spine, from his small cell. So Larry died, and then his family, who are extremely successful, they're privately owned company. Delaware North is the largest concessionaire in the country, and it's all privately owned. 30 years ago, he bought the Boston Bruins and then the Boston Garden. And I said, Jerry, why did you buy the Boston Garden as well? I mean, your business is basically, the Bruins are the epitome of what a wealthy guy would want to. He said, Boston Garden was very special for us. We did our homework and we found out that we're in the concessions business, and the people of the city of Boston drink more beer per capita than any other city in the world. So that's why he bought the garden. So anyway, a bit of a personal journey of when the Jacobs family approached me and asked me to help them to memorialize Larry's life. They wanted to build a neuroscience center, and I said, well, why? Because Larry was first a vascular neurologist, but more important than that, a neuroscience center, everybody's doing that. Let's do something different. And they agreed that we would. And it based on this, if we look at the impact of this disease worldwide, everybody knows it. But what's interesting is neurocardiac and peripheral, it's the same diseases, the same arteries, the same vascular highway, similar tools that we all use, although we're learning about each other's tools, which is really helpful. Why are we not all together? And that's why I'm excited to be here with you guys today. So the mortality impact, you all know it better than I do. The impact of acute stroke, number 3 or 4 cause of death, but by far the number 1 cause of adult disability. And I think the number of strokes keeps rising across the world as our populations age, as you can see here. The high burden on society, obviously there's a huge economic burden, but what's even more important to me is the personal and social burden. I mean, we all have, Uncle Johnny, who's in a nursing home, who we kind of have to go to see every week because he's part of the family, but Uncle Johnny is aphasic and hemiplegic and drooling, and you don't really want to go, but you feel like you got to go, and there's this guilt thing. Well, the impact of a stroke on a family is just devastating. So the financial impact, yes, but the personal impact is absolutely huge, and a lot of it's preventable. So what I want to kind of talk a little bit about is pushing the envelope, more focused on the way we deliver care and on a med tech entrepreneurship exercise that we've been going through. So let's just say a word about innovation. It's all about collisions, collaboration, and innovation. You're going to hear me say that a bunch of times this morning. Innovation, a new idea, a more effective device or process, the act of starting something for the first time. But by golly, it better be desirable to the users, and it better be possible with current technology, and it better be viable in the marketplace. And entrepreneurship, interestingly, was invented. The term was invented only about 65 years ago by Schumpeter in 1950. The process of converting a new idea or invention into a commercially successful innovation. So where does innovation come from? This is where I think it's most interesting. It comes from the trenches. It's from you guys doing a case and realizing, damn, if I could just get this device to do X, and it won't work. And so new idea pops up. And it's from the intersection of disparate disciplines. It's people talking together. It's scientists talking with clinicians and things like that. Most importantly, what we talked about last night, it comes from failure. When we fail at something, we got 2 things we can do. We can give it up and quit, or we can find another way to do it. And that's where real innovation occurs. And the part that's, I think, most troubling is that most great ideas lie fallow. They lie fallow because we get an idea, we're busy, we're afraid to tell anybody about it because somebody will steal our idea, and we've heard that story over and over again. And then we're off to our other patients, and first thing you know, a week's gone by, a month's gone by, you haven't done anything about it, and it never happens. And that's a real tragedy. I love some of these words of wisdom. If at first the idea is not absurd, then there'll be no hope for it. He who asks a question is a fool for 5 minutes. He who does not ask a question remains a fool forever. So, yeah, ask questions. The difficulty lies not so much in developing new ideas as in escaping from old ones. Ain't that the truth? And I haven't failed. I've just found 10,000 ways it won't work. And so that's kind of where we're at. Innovation in healthcare delivery. We set out to try to build what we thought would be the vascular center of the future. I would say it was a bit of an experiment. The jury's still out as to whether this will be the paradigm for the future, but it's what we've done, and we're beginning to see some incredible synergies from this. Why a vascular center in Buffalo? And the answer is very simple. If you look carefully at this map and then you focus at that little tiny corner on the entire, rather the left or western end of New York State, there's a little black dot that matches the black that you see along the stroke belt in the southeast, and that's Buffalo, New York. So people keep asking me why is Buffalo so high in cardiovascular disease and stroke? We're the highest in the Northeast, matching the stroke belt, and the answer is simple. It's because of chicken wings. They were invented in Buffalo and at Teresa's Anchor Bar, and just to show you how crazy it is in Buffalo every year, we have the only city in the nation that has an annual chicken wing eating contest. And last year, the Anchor Bar brought in 45,000 pounds of chicken wings for their contest. God knows what it'll be this year. But our population is somewhat sedentary, a lot of smokers still. It is a community that likes to have a good time, but very sedentary through the winter months and so on. So heavily Eastern European background. So all those things come together to make us the area where it keeps us busy doing cardiovascular disease day and night. And the ultimate irony, when you look at Teresa's Anchor Bar, is it is right across the street from the Vascular Center. And so we did think about building a zip line between the two. So why a Vascular Center? It's pretty darn simple. It's the #1 crippler and killer, and all of us work in silos. And I know you guys are coming together a lot more than other places, but still it was a long walk over here from the vascular surgery department over here. And so all of us work in silos in our own institutions, and we rarely have the time to actually interact with each other. And that's true of our scientists as well. They work in their own silos, and they don't see each other. And they sure don't come down and spend a whole lot of time with us as a rule. So we're all in a siloed society. And our goal #1, break down those silos if we possibly could with our new center. And then could we somehow change the treatment paradigm to bring to bear all the vascular disciplines together to work on the entire vascular system? And then the third part was to build the Jacobs Institute. And the idea for the Jacobs Institute was an independent center for innovation in cardiovascular disease and to focus on collisions, collaboration, leading to innovation. So 3 goals: break down the silos, change the treatment paradigm, and innovation in devices and drugs. And the prerequisites were collegiality, collaboration, sacrifice your ego. Leave it at the front door. You don't have to be a big shot. We just work together. We needed a bunch of money, and we needed to be willing to take risks. And we needed to build a building construct that would force everybody together. So this is the building, and it's kind of a weird-looking thing from the outside. This is the architect that made this possible. The Jacobs family funded all this, and we all came together at our complications meeting out in Jackson Hole. We pulled together about 18 or 19 of the guys across disciplines who we thought were most innovative and interested in doing this. And we just brainstormed with this architect about what would be the vascular center of the future. And the first things that came up were connectivity, collaboration, flexibility. And after the first hour or two, he looked at us and he smiled and he said, "You guys are telling me that you want collisions. I'll help you make that happen." And then we also wanted to focus on patients as partners, so real focus on clinical research, and on the university as a partner, but not with control. The hospital as a partner, but not with control, and with industry as partners. This was a big deal. With all the emphasis pushing industry away from physicians lately, we said this is complete nonsense. So the Jacobs Institute is independent, and we don't have to live by the rules of the hospital and the university. So we have actually put offices in our institute for industry. When they're there, they get an office. All about convergence, bringing everybody together. This Jackson Pollock. So the vision was a freestanding building connected to the hospital, partnered with the hospital and the university, but independent from both. Physician-led and governed, and I will say we're not quite there yet, although we're getting there. Minimally invasive treatment, vascular disciplines and scientists working together, so all in one building. And the Jacobs Institute is an independent partner with the hospital and the university, focused on collaboration and innovation. So as Donnie said to us, I'm going to build you guys a club sandwich, the Science Center on the top and the Vascular Center on the bottom, and the Jacobs Institute is going to be the meat in my club sandwich because it's where everything's going to happen in innovation. This is the building we ended up with. The top floor is the Toshiba Stroke and Vascular Research Center, and then there is the vivarium, and all the other vascular researchers coalesced into that upper building. We've got 2 full-blown angio suites. We've got 3 TCMRI and a 640 CT scanner that's going in, and all the rest of the imaging disciplines, all complements of Toshiba with free lifetime support, all for research. The Jacobs Institute is defined by that ribbon you see on the building. The cath labs are all on the 4th floor. That's why the building had to be 1 acre, because we wanted to put 16 cath labs on 1 floor. Immediately below are the vascular ORs, all convertible to cath labs because we believe 20 years down the road there may not be any vascular ORs anymore. They'll all be interventional suites. And then a hotel, which is 62 private beds that are all designed to handle the pre- and the post-op work. So patients admitted directly to his hotel room, goes up to the cath lab, and this is elective procedures, obviously, goes to the cath lab, right back to his hotel room, and all the post-op work, pulling sheaths and so on, occurs in that room. A little bit elevated level of nursing. The emergency room directly below, so if somebody comes in with an AMI or a stroke, they're going to go straight to headquarters. And this is the way it works. AMIs don't get past the front door. They go straight to the cath lab. Strokes have an intermediate stop in CT because we got to know whether the brain's viable or not. And that takes a very short period of time. It's like a 5-minute acquisition, which gives us CT angio, and CT perfusion. Then we go to the cath lab. STEMI, really interesting, isn't it? The paradigm for STEMI is exactly what we're now beginning to follow with stroke. So it's the same disease. The outpatient experience, again, more like a hotel. And this is the way it works, which I just described. What I didn't describe was that we got Cisco to put in a video conferencing link between every cath lab and every private room, all the 62 private rooms on the 2nd floor, so that when you come out of a case, you immediately get to talk to the family about what you did. You can show them the images and tell them what you want them to do post-operatively, and all that is eventually going to go to a web portal so that the family or the patient can pull it up a month later when he's forgotten what you told them. So here's the 4th floor design. The outer area is patient access. Cath labs next level in. Control rooms the next level in. All interconnected. And every tech and every nurse is cross-trained. So everybody there can do multiple disciplines. Of course, that increases flexibility. So if you got a neuro case and you don't have enough bodies, you can ask somebody from cardiology to come over and help, and they know how to do it. The core area is basically designed for open communication. You can't come out of a neuro cath lab and not run into a cardiologist or a vascular surgeon. So, excuse me. So bottom line is everything's designed for communication. All over the core area, you see these little conference areas. You can share a case, talk about a project, and these little conference rooms, which we call the fishbowl for vascular conferences among disciplines. So talk about MI. It's basically the same evolution with stroke. Cerebral and coronary occlusion, exactly the same end effect. Sure, stroke is more embolized. Cardiac is more plaque in situ. Initially, we all treated with lytics, and now we've realized that lytics don't work so well. Oh, thanks. And, of course, time is brain just like time is muscle. Collateral is key. Revascularization is now known to be the best treatment for stroke as well as heart attack. And we're just a little slow in neuro. We never said we're all that smart. We're about 10 years behind you guys in cardiology. But it's all about saving the penumbra, which you all know well. And here's where it gets really interesting. Stroke, a lot of it's from the heart. So cardiologists needs to be involved. And a real stroke center should involve cardiology as well as all the neuro specialties. We should all be in this together. So the evolving landscape changed dramatically a year ago at the stroke meeting in Nashville. 5 major trials proved beyond a doubt that stroke intervention works for stroke. Is it as good as the treatment for AMI? No, not yet. We got a long way to go. Technology we have is very primitive, and we're just gradually evolving. And finally, now we have proof that intervention works, and now industry is jumping in. So in the next decade, we're going to see an avalanche of new devices and techniques for treating stroke. And then maybe we'll get closer to where you are in AMI. It's pretty simple. If you got a blocked artery like this, I mean, everybody can see this. What's the solution? It's not to squirt a bunch of lytics into the patient's vein. It's to open up the artery, and we've got a bunch of early stage devices. This was the first stroke we did in our new vascular center, and the paradigm is going to sound just like AMI. Door to needle, 48 minutes. Needle to revascularization, 12 minutes. Stroke scale, 17 when the patient came in and 1 after the procedure. And the synergies are freaking incredible. So I'll just give you a couple of examples. One of our guys is doing a subclavian, and the wire gets away from him. Next thing he knows, the wire's gone down through the aortic valve, and it's gone into the atrium, and it's tied itself in a knot. So he gives it a little tug, and the patient's not liking that. Right next door, 2 cardiologists, they came over, they figured it out and got the wire out. About, I don't know, a few months ago, there was a cardiologist doing, there was a patient with saphenous vein graft, 10 years out, full of grummus material, patient symptomatic. They went in to stent it open, and they put a filter wire down distal, collect all that debris, to try to prevent no reflow. And what happened is everything was cool. They put a stent in, and then they went to retrieve the filter, and they couldn't even get the retrieval sheath up through the stent. It got caught in the stent. After 15 minutes, beads of sweat, nurse says to him, go get one of the neurosurgeons. They get these things stuck all the damn time. So, so they did, and with a little simple, hockey stick catheter, we were able to work our way through where you couldn't do it with a straight sheath and get the thing out. So it's those kind of synergies. Cardiologists are, they hate the transapical approach. It's got a higher morbidity, takes more time, it's a pain in the neck. But transapical is the only choice for patients with no access until the guys were sitting around one day, this is a couple of years ago, getting ready to do a TAVR on a patient with no access at all, iliac occluded and the whole 9 yards. And one of my partners, Siddiqui, says, it's a straight shot from the carotid. Let's measure it up, and if the sheath is not too big, let's try it from above. Once they got the carotid open, it took about 7 minutes to do the procedure. And now we've done, I don't know, about 9 or 10 of those. And so it's a wonderful alternative that just came, it's in the literature already, I'm sure, but it just came from guys hanging out together from different disciplines. So if there are any neurointerventionists in the room, I suggest now's the time for you to leave, because I'm going to say something that is sacrilegious. But it's what I really believe. There are 900,000 strokes in the United States every year. There are about 250 interventions that will be needed this year, and that number is just going to go up like this. We got maybe 600 card-carrying neurointerventionists who actually get out of bed and treat stroke. and in a 24/7, 365 environment. And yet, time is brain. You cannot argue that. We need a whole lot more people treating stroke, and where I think they could come from very easily is from the 8,000 interventional cardiologists. Okay, what's important here is population health and not turf. But there's a lot of turf going on. What do cardiologists do all day? They fix stenosed arteries. Really? What do neuro guys do all day? They coil aneurysms, treat AVMs. I say they, I mean we. And cardiologists do it on awake patients in a moving target. Neuro guys, most places we don't, but in most places, and I bet they do here, you put them to sleep. Completely different environment. So we are at the dawn of a new era with new proof that intervention works, and we need a STEMI model for stroke. We need mandated door-to-balloon times and all that kind of good stuff. Well, let's look at the infrastructure. Infrastructure for cardiac. There are about 1 million PCIs in the United States annually, over 2,000 cardiac cath labs, 8,000 interventional cardiologists, a lot of interventional radiologists. Contemporary cardiac cath labs have DSA and road mapping. And acute stroke intervention, what's it about? It's about removing clots. It's about angioplasty. It's about stents. And cardiologists and interventional radiologists are all experts in that. So the conclusions that come to my mind are revascularization of a stroke is a real emergency. You don't have time to transfer a patient 2 hours to a major center where you got neurointervention. Cardiologists have got the skills. They need training, but they have got the basic skill set to do this. And they have the right mindset, getting out of bed in the middle of the night. The infrastructure is already in place. There are too many strokes for INR to handle at this point, and if we trained up enough people to treat all the strokes that are neurointerventionists, there wouldn't be enough work for them to do all the rest of the things that don't exist. So my gut is the future is treat and ship. We talk about drip and ship, but treat and ship. Treat in the nearest cardiovascular center. And if it's an interventional cardiologist or radiologist, fine. They just have to learn how to do this. And it ain't that big a deal. It's not rocket science. So all these things are coming together, aren't they? This is one of my favorite paintings. Anybody know who this is? Miro, the Carnival of the Harlequins. All this disparate stuff coming together. So a word about the Jacobs Institute. The mission, change vascular care delivery, create a nidus for innovation. Try to develop a high-tech corridor, and industry and FDA collaboration, which is woefully inadequate in our opinion today. Collisions, collaboration, innovation. So if I look at the innovation, or rather the evolution of devices in neuro, it's pretty crude. Pretty crude. Where are we today? With stents and clot retrievers and aspiration. And the technology, why is it crude? Because there's been no reimbursement. Why should industry go after this with no reimbursement? We need to fix that. This is the Jacobs Institute, our what we call I2R, or Idea to Reality Center. It required a lot of partnerships that were sometimes difficult to manage. Partnerships with the university. I was an anathema to the university that I thought the JI should be independent from the university. They just didn't get it. We were leasing space from them, but we got a 45-year lease, and they've been after me ever since to try to make it fail so they could take it over. Because how could anything be independent from them? From the hospital, same deal. Although the hospital didn't really have a clue what we were doing anyway, so they didn't care. New York State, we needed a partnership with New York State. We had to raise $300 million, and we got a lot of it out of the state. Toshiba, a critical partner for us that came through with huge support with imaging. Philanthropy, of course, and investors. So we've had to sort of assimilate all that. I mentioned it before, but Toshiba's contribution is extraordinary. Everybody has a contribution to make. The Toshiba gift was actually to the university, but we have control over it. So the Jacobs Institute, clinical, academic, research, and entrepreneurship. Jerry's money to recruit superstars. On the academic side, Alan already mentioned we have a pretty robust academic infrastructure. We have full-time medical illustration, editorial staff, photography, et cetera, just like you guys have here, all dedicated to assist clinicians to get things into print. Because if it isn't in print, it doesn't exist, according to the government. And then research, of course, a focus on clinical research. The hospital is really doesn't know much about clinical research. The university is great with government-sponsored research, but it's a disaster for industry-sponsored research where speed is so important in university. The word speed to a university bureaucracy is an anathema. And entrepreneurship. So, innovation in medtech, what's it all about? It's about a lot of money is what it's about. If you look at the amount of money that goes into a startup company before it actually gets acquired, it's huge. And so money is a real barrier to innovation. So how does innovation occur? We start with a smart guy, somebody in this room with a great idea. And what do? I mean, here you got to talk to the university about IP, but then you got to raise some money, and you got to do the IP search, you got to do the market research, you got to find out, is there a pathway through the FDA for my great idea? Because a lot of ideas that we see might take 20 years to get it through the FDA. You might as well not even do it. And then the economic feasibility. You know, the FDA, I get the biggest kick out of this. It used to be the FDA was the barrier. If you get a new device approved by the FDA and they determine it to be safe and effective, that's the FDA, right? If that happened, it was pretty much automatic reimbursement. CMS had a little bit of a budget problem, so they came up with a whole new paradigm. No, we don't care if it's safe and effective. It has to be reasonable and necessary. What does that mean? It means they get to pontificate about your device, and if you can't prove that it has economic feasibility, you're out of luck. So, case in point, carotid stenting. Where are we with carotid stenting? It's a disaster. We all know it's an important procedure, a great alternative to patients who aren't good candidates for endarterectomy, less invasive and so on. What, maybe less than 10% of all carotid stenting gets reimbursed in this country today, just because of that. So once you get it to that stage, you got to make a prototype, and that costs a lot of money. And then you got to test it in models, simulate it, test it in animals, go around the horn and fix, redesign, fix and redesign until you get it to the point where you've really got proof that it actually is going to work. Now, once you've done that, we call that the first valley of death, because most ideas fail in that period. But it's going to take you a couple of years. It's going to take you a couple $1 million, a lot of energy, enthusiasm, faith, and so on to get it to proof of concept. Most times, a company starts right in the beginning, and it has to spend all that money to get to proof of concept. So here's what we're trying to do. What we want to do is take that first valley of death out of play. Okay? Our idea to reality center, idea to proof of concept, we want to do that for you. And we want to do it free of charge for you. We want to take philanthropic dollars to fund that in the JI, which is a non-profit entity, and in an independent environment. We have the university and the hospital around us, so we've got the clinicians and the scientists everywhere, but they don't own us. And so what we want to do, we can do when it comes to innovation. So, nascent idea to commercially ready product. We don't have any interest in commercializing. We're not for profit. No upfront cost to the inventor. The JI gets equity or royalties if it is successful. We think it's going to take 5 to 10 years before we get to a stable business model where the JI is fully independent based on royalties and equity payments and so on. If it fails anywhere along the line, and we hope if it's going to fail fast, then no cost to the inventor. And if it's successful, we get to proof of concept, then we take a piece, small piece, 3, 4, 5%. Then the JI has developed relationships with a number of accelerators, and we'll help you to place it in an accelerator. Most of them are on the West Coast, as you well know. Some also a pretty hot area in Minneapolis and Boston, and I'm sure Houston too. But we'll help to place you with an accelerator, and we're going to create a fund for startups to give you a startup funding to get the company going. So, basically, philanthropy in an independent, not-for-profit environment in the middle of a clinical institute to fund innovation. I think it's something that's a little bit unusual. In the goals, innovation, develop for-profit companies with new technology in a self-sustaining environment in our institute. Where do we get the ideas? They're going to come from all over, right? They're going to come from our institution. They could come from here. They could come from anybody that's got a great idea who wants to have it developed and doesn't have the resources to do it himself, and who's willing to work with us and give up a small piece of the equity. It could come from industry. We've said to industry, you got a lot of stuff on the shelf that you don't have the bandwidth to develop. Give it to us. We'll develop it for you. And you can pay us for it, or you can pay us royalties after, but again, a source of revenue for the JI. Idea, all the way through all these things we just talked about to proof of concept. Take science and turn it into a business. Take risk out and create value. Kind of like put it all in at the top and go through all these processes, and what comes out the bottom is proof of concept. Think of it as a bunch of hurdles. And we've got a 9-step process. Starts with an application, goes to idea analysis, then goes to intellectual property search. And here's where it gets interesting. So every one of these steps, intellectual property, assess the market, clinical regulatory, and economic feasibility, are all in partnership with the university. So what's in it for them? Their students get lots of wonderful experience. We have in-house expertise in all these areas, or consulting expertise. At this point, mostly consulting expertise. But we're with Noby Martin on the West Coast for IP and so on. So what the students get is an exposure to developing IP, market research, clinical regulatory, and so on. And what we get is free labor. Pretty good deal. When we get to prototype development, we've really gotten to the point where we really are pretty sure we can make this happen. And then device testing, as we talked about, all the different stages, to proof of concept, that this thing actually looks like it's going to work. And this is just a list of the partnerships that we have going on with the university. When we get to making a prototype, university engineering prototypes are working with us. Great experience for them, and wonderful opportunity for us to have additional help with our biomedical engineering staff in the Jacobs Institute. So how do we sort of think of ideas? We brainstorm. Somebody's got an idea for a new device for a given procedure. We'll just bring up live cases, and I'm sure you do that here too. But we sit around in our boardroom and watch live cases. There's a whole group there this week watching live cases, and we think about, okay, what do I want to do? We get it through the process, and then we'll make a prototype. We have a whole prototyping facility. We can make catheters, wires, balloons, stents, and so on. If it's too complicated for us, we have a partnership with Lake Region, which can make virtually anything. Then test. One of the fun things that we've developed, and I know you have it here, we've taken 3D printing and we've developed to a point where we now take patient-specific 3D anatomy from the CTA, is the most common. We take that data set and import it into the 3D printer, and our physics group developed a polymer combo that when you print it out and clean it up, it actually put it in a flow model and put a catheter, and it feels like the real deal. So it's not like most of these models you see where the catheter is sticky and doesn't go right. And no, this really works pretty well. So here we are in a flow model, and so you got a new device, you just made a prototype, stick it in a flow model, see how the damn thing works. Take the same data set and program it into the simulator. 3D data set from any patient you want. So with a new device, you'd print out easy anatomy, intermediate anatomy, and then impossible anatomy. Print out 3 or 4 different patients, and then test it in all 4, both in 3D models and in simulation. And then when you get to the point where it looks like it really works, you take it upstairs and put it in an animal, and in our Toshiba Center upstairs, and you basically get to a point where you really think you've got proof of concept. As I've said last night, we got to a point where we're all set, we're ready to go, the door's open, and our benefactor comes to me and he says, how are you going to pay the rent? I said, well, I told you it's going to take 5 to 10 years. He said, no. How are you going to pay the rent now? And so I scratched my head and we started talking about it. And then we realized the exact same process that we use to develop a product is perfect for advanced training. So necessity is indeed the mother of invention. And we found that testing is the same as training. And testing yields revenue for us. So that's how we're paying the rent. So we do training sessions, live cases, didactics, 3D models, animal models, simulation. It's perfect. And it's great for industry. And it works for us for revenue. So this is kind of complicated, but this is sort of the way it works. Training in clinical immersion. We call it clinical immersion. We take a group of engineers from a company and immerse them in the environment in the JI for a week. And that goes to, we train the engineers. That goes to industry, which can go to products, to the I2R, product development, JI revenue. So you see 3 areas where we can develop revenue for the Jacobs Institute. We can get money directly from industry, either for training or for developing a product. We can develop a product and have it turn into something and take royalties, and so on. So this building is, one of our visitors one day after spent a little time with us said, we should rename this building the Shaft. I said, well, why is that? He said, because the entire innovation cycle can occur in one building. No matter what it is you need, just get on the elevator shaft and go up and down, and you'll be able to find it in this one building. So the life cycle that we're working towards, philanthropic contributions to the I2R, create devices, then start up a company with not us, but it leaves the JI at the devices point. A company starts with venture capital. That generates royalties and equity, which can come back to the JI, creates a medtech corridor, and eventually creates more philanthropic contribution. That's the concept. And this is a little complicated, but saying the same thing. Philanthropy to fund the I2R products, companies. And then when you finish, we don't have it yet, but we're going to develop a seed fund to help companies get started. And just more of the same. You know what's cool? And Alan, you said this to me last night. People get so excited when they come and visit us. They want to be a part of it. And the gifts that we've had have been amazing. 3D printers and simulators and robots and so on. The companies want to have them in our place so they can show them off. So, and all of our trainees are becoming ambassadors. So it's really exciting. So the future is we hope for a thriving medtech community, an economic driver, and world-renowned vascular care like you guys have here, and a magnet for superstars and so on. And I just finish by saying we've got a huge opportunity, and we want to take that shot. And it reminds me, if we don't screw it up, it reminds me of this little note that was, this is an actual note sent by an 8-year-old girl on her first flight. She was on a Qantas flight from LAX to Sydney, and 2/3 of the way through the flight, she sent this note up to the captain. Said, "Dear Captain, my name is Nicola. I'm 8 years old. This is my first flight, but I'm not scared. I like to watch the clouds go by. My mom says that the crew is really nice. I think your plane is good. Thanks for a nice flight. Don't fuck up the landing. Love, Nicola. So if we don't screw this up, I think we've got something really exciting here. And I would invite you all to come innovate with us. Thank you.
Thank you very much indeed. Now, we've been banning Neil Kleiman for years for using the F word in the presentation, so you probably set a new norm here. Anyway, spectacular talk. I thought, I'm sure there are going to be questions. Let me just say that this is all being recorded. For those of you who are not on part of our Facebook site, so we use Facebook to tell people what's going on in the Heart Center. All of this is recorded. You can download these, and you can listen to this lecture when you're working out. And, I usually do it in the gym on my iPad once every month. Yeah. Pardon? Yeah. No. All righty. Questions? Neil.
Yeah. So two questions. Who do you work for?
Yeah.
Everybody.
Yeah, I
This
know,
is a
but-
very, very difficult challenge for me. I've many times I've heard the dean of the university of the medical school say, "God damn it, he works for me. Why isn't he doing what I tell him?"
Right. That's why
I work for the hospital. I was the first president of the GVI, so I work for the CEO of the hospital. It's completely independent from the university, so there are conflicts there. I worked for Mr. Jacobs, and balancing all those has been the challenge. And I will say, I just try to do the best I can.
Yeah. So I'm really trying to. What I'm really asking is, tell us about the negotiations with the university or the hospital.
Yeah.
I know what the hospital would do to us if we proposed an independent institute. It wouldn't be pretty, and you guys would probably be working on us within an hour.
Well, we were lucky, very lucky, and I said this to Ellen last night. Our benefactor, Jerry Jacobs, happens to be the chairman of the board of the university.
Ask and answer.
It's good and bad. It's good because throughout the negotiations in the beginning, when anybody said no to me, I just called Jerry, and he made it happen. But what I didn't really count on, one of my biggest mistakes, was that a lot of everything. I've been carrying the university flag as chair for 25 years. And so I've university blood in my veins. I am a university guy. But there are things that the university just cannot do as well as an independent entity can do. So we love the university. We work for the university. Everything we do is directed to make the university better. And in the areas where they just are going in a direction that we know is not going to work for, say, industry-sponsored relationships, then we try our best to navigate those waters and to get the university to play ball with us. But it is a challenge every day. And I'm in the doghouse, I'd say, half the time with somebody.
So switch gears for a minute. How much neurology do you have to know to intervene on a stroke? So we know what, in cardiology, if someone's got an MI, we know what vessels we can sacrifice. We know where to stop we know when going further is too much with little gain. If you put me in the brain, I'd be lost. Right now, I wouldn't be able to tell you what would happen if I stented across a branch or pushed a clot into a branch. How much do you have to know?
That's a great question, and I think you don't have to know a heck of a lot. And I say that because I think the paradigm will be going from treatment to transfer. And if somebody has a straightforward problem, and you take a clot out, you're done. And the patient's going to more than likely do very, very well with a few basic caveats, which you probably know well from cardiology. If it's a more complicated problem, then get the clot out and then ship the patient. I mean, why do you have to ship the patient while the clot's still in there and the brain's dying off? right?
Yeah, but I'm more concerned if I open the main branch and I have a side branch that I've pushed clot into, do I have to struggle to open up that side branch or not? So
Yeah.
you guys know that.
That's another.
I don't.
That's another terrific question, and I think the beautiful thing that we're going to see happen over the next decade is the technology will evolve to the point where it'll be very, very easy. Because we had a case 2 days ago where we took a big clot out of a right PCA, and it was one of those pencil eraser clots that probably came from the left atrium. And as we pulled it back, it popped into the good posterior cerebral artery. And then we spent the next half an hour trying to get it out of that. So we all are going to face the same issues, and it's really, I think, not that much different than it is in cardiology.
So Nick, let me, because you're carrying this message across the country about acute intervention, and let me broaden it out a little bit. I think the cardiologists, if you told me in this organization 5 or 6 years ago we could go door to balloon time in 90 minutes, I'd have said it's almost impossible. But it's been done, and it came because national benchmarks were set, and you were reported, and we were reported for not meeting those benchmarks. So having national guidelines certainly helps push the ball forward. Likewise, now basically reperfusing, what is it now, 3 hours? You've got to basically reperfuse the brain. As a vascular surgeon, what infuriates me is that a patient with an ischemic leg who arrives in the emergency room or basically is diagnosed up on the floor is not treated in the same way. And I would say this should be about acute vascular occlusion, not about the coronaries and not about the brain.
Exactly.
And we tried to create an acute aortic treatment center. We created it. The idea, if you have a type A dissection, you have a 1% mortality per hour, the highest mortality reported, and yet that patient will dwell in the emergency room, dwell getting them back in the operating room, and it is the quintessential example of how speed equals survival. But we're picking this off, one area at a time, really based upon specialties pushing that forward, and that we should be treating the patient with an acute renal occlusion, acute leg occlusion. That is an emergency. Right. And just because it happens to be your leg that's ischemic, not your heart that's ischemic, you deserve the same kind of priority.
Exactly, and that to me is why, with all due respect to interventional neuro, I think that we in interventional neuro just don't have the manpower to take care of the stroke in the optimal fashion. So when somebody comes in with an acute stroke, they're always going to probably end up at their local hospital first. Now, if it happens in Houston, well, sure, it's going to come to a major stroke center. But if it happens 200 miles away, there's going to be an interventional cardiologist with a cath lab, but there's not going to be an interventional neuro guy. And so I think if we can train cardiologists, which I maintain will not be that difficult because they do the same stuff all day. Yes, the coronary arteries are tougher. They're easier to deal with. And the access is more challenging in the neuro because of the skull base. Yes. But the bottom line is taking a clot out isn't that complicated. It's that current technology just isn't that good. But down the road, it's going to get much, much better. So what I'm talking about is, a public health issue that a decade from now, we should all be working together, just like Alan says. We should be working together to do the best thing for all the patients. And think about it. If you trained up another 5,000 neurointerventionists, what are they going to do all day? Right? We might maybe treat 30,000 subarachnoid hemorrhages and another maybe 30,000 unruptured aneurysms every year. That's 60,000 patients. There are about 5,000 or 6,000 AVMs that come up every year, and there's even a question what we should do with those. And so there just aren't enough things to keep an interventional neuroradiologist or neurosurgeon in business if he just focuses on stroke. There's just not enough.
Sid, question?
I'd like to posit the idea from a global point of view that the brain and the heart are completely different.
True.
And I'd like to know what the basic scientists think about how much time does it take for a myocardial cell to die when it becomes bereft of its circulation, and how much time does it take for a neuron to die when it's bereft of its circulation. I think there's a difference.
You're right.
Secondly, you can lose part of your heart, and if you don't die of a arrhythmia, you can survive all that. You can't lose part of your brain without and survive that without a terrible catastrophe. So whereas from a global point of view, your presentation is accurate and right, I think there has to be some understanding that you guys are never going to be in the position that the cardiologists are going to be in, because the basic anatomy and the basic physiology are so completely different, even though both of them are perfused by the same red cells.
That is a great point, and I agree completely. We'll probably never get to where you are in cardiology, but it's the same basic pathophysiology. It's a blocked artery that's causing the damage, right? So, if you can get the artery open, and I would argue that that even goes further towards supporting the need for cardiologists, because if you can, the brain cells are far more sensitive. They're exquisitely sensitive to anoxia. And so it's even more important that we take speed into account and get patients treated, that is, get the artery open and the patient revascularized as rapidly as possible. So, yes, they are very different diseases. The pathophysiology is completely different, but it's the same net result. And I would say that, interesting, your comment about damage to the brain is different from damage to the heart. I would argue with that. I would say that the hope is that we can save the penumbra. If we can take somebody, now if you look at what's going on today, only about 20% of the patients that were treated in these 5 major trials actually went back to do exactly what they were doing before. So there are some patients that aren't capable of going back to their previous employment. But another 45% are functional members of society that are, they're living alone, they're taking care of themselves, they're doing, things, they're going to parties, they're having a good time. So they're not perfect, but they're a lot better than somebody in a nursing home who's aphasic and hemiplegic.
And your argument that quality of life can be saved by this is fine. I agree with that. But do those patients die farther out than the patients who you don't do this with?
Well, I'm not sure I understand the question.
What's the mortality rate of that? If only 20% of the people that you work on get benefit, what happens? Do those people survive longer than the other 80%?
I mean, if you get good reperfusion?
Yeah.
Oh, sure
they do well.
Sure they do. Sure they do. If you look at IV TPA at 3 months, IV TPA, and you neuro guys correct me, about a third are dead, a third are disabled, and a third are restored to some reasonable functional state, right? That's IV TPA. With removal of the clot, huge difference. 20% are completely normal. Another 45% are very functional. So we still have a ways to go, and we'll probably never get to where you are in cardiology because the brain is just far more exquisitely sensitive to ischemia. But we're far better off than we were, and it's only going to get better.
So before I give Orlando the last question, I mean, sometimes these arguments are based upon specialties in a big medical center. Here, for example, very difficult for us to justify having non-neurointerventionists go ahead and take care of these stroke patients because they do a great job. But our job is to take care of the health of the American populations, which I see that we are primarily subservient to. And the majority of those people are not within 10, 20 miles basically of a major stroke center. And there I can see this argument in training up another group as being absolutely worthwhile when they don't have direct access to neurointerventionists.
Right. About 55 to 60% of the U.S. population lives in rural areas.
Yeah.
That says it, right?
Yeah, that says it. Orlando? Richard?
I've been doing neurointerventional for 25 years, and I've been here 22 years now. And I'm going to come at this from a role of patient care and who does the best job at doing stuff. And the controversy that you just raised about cardiologists doing this has been raised in some of the journals. What troubles me is the attitude of some of the cardiologists when they say you can take an interventional cardiologist and give him a course for a weekend and he can become a neuroradiologist and do stroke. That is the absolute wrong attitude to have. That can't be done. We're going to kill people. The Society of Neurointerventional, which I am a board member, has put out guidelines. And if a cardiologist wants to go through the proper training and follow those guidelines to do cases and train properly to do stroke, then we agree with you that people can be trained to go out in the periphery. But it turns out that a lot of people don't want to do that. They think they can handle stroke because a vessel is a vessel is a vessel. And there's already been one institution where cardiologists tried and they were doing stroke and they've been asked to stop because the complications were so horrendous. I, treating stroke, and I've been doing stuff for many years, have caused subarachnoid hemorrhage. So we can't hurt people. I agree, and we agree, that there are people that need treatment, rural areas across the country, but we can't sacrifice patient care to do that.
Completely agree. You're making a very important point. They need to be able to understand the basic anatomy and physiology. But I think where we might differ is in the guidelines, to my mind, are to some extent developed partially as a barrier to entry. And so I think that's where I disagree with the society, that, you know, creating guidelines that are so onerous for a cardiologist to get involved is just not fair. And what has been more troubling to me is when industry supports a meeting to teach cardiologists about stroke, and the society comes in and raises hell with industry. I think that's unconscionable. There's no reason why cardiologists shouldn't learn about stroke. And I would also say that it's very individual. There are some cardiologists who would probably need, you know, an extra year of training. I don't know, but it depends on the individual. And what I would propose to you is that what would be really helpful is if there's a cardiologist in this shop who's really interested in stroke, that he rotate on your service, and that you teach him how to do it, and see what it takes. We've trained a few, not a lot of cardiologists, and I'm amazed at how facile they are when you put a catheter in their hands and let them go upstairs. They're very good. You have to be aware of the fragility of the intracranial vessels, and the technology is very helpful to enable you to do that. So no question, you are absolutely right. And what we want to take care of our population. We don't want to hurt people. So you don't want to have a bunch of cowboys going willy-nilly up there. And the biggest fear is that, you know, reimbursement comes to physicians, and then every Tom, Dick, and Harry goes up and starts trying to grab clots and is doing a lot more harm than good and doesn't know who he's treating and who he shouldn't treat, and so on. So I think there need to be for very definite guidelines, and there needs to be training, and there needs to be an understanding by the cardiology community before they venture into this. And a lot of them are probably not going to care or have any interest, but there are some who really do care. And then the way to start is to basically inculcate them into the neurointerventional world, because, you know, the things we do every day, putting catheters up to treat aneurysms and so on, is great training for a cardiologist. And once they learn all that, stroke becomes very easy for them.
Okay, last question. The other disclaimer, I had no idea he was going to approach into the subject. I didn't put him up to this. I thought he was going to talk about innovation, but that's certainly innovative. Yeah.
Quick question. How your institute integrates with the hospital? Which are the patients that go to your institute, and how you work with the hospital, how you decide which patients?
Our institute is a partner of the hospital, but we do not do any clinical work in our institute. It's not a clinical entity. All that's done in the hospital. Yeah, so what goes on in the hospital and the university are what go on normally in hospitals and university, and the Jacobs Institute is just it's a partner. We like to think we're an invaluable partner to the university, and there's not a thing we do that we don't take into consideration how important it is to develop the university relationship as well as the hospital and the Jacobs Institute relationship. Our goal is to strengthen the university, but think of all the things that the university can benefit from an independent JI. It's just that the bureaucracy in a university, like all universities, it's single-minded, and it's very complex, and it takes much longer to do things. Like industry-sponsored research. It shouldn't take 6 months to get a proposal from industry that's already been vetted by the FDA.
Yeah.
Shouldn't take 6 months to get it through a university IRB. And it's just because of the nature of the bureaucracy and the fact that university IRBs are populated with basic scientists who don't really understand what we're doing.
So the final question is going to go to Dr. Zogby, who's a newly anointed chairman of cardiology. You're about to set 2 records. One, using the F word, and number 2 is we've never gone 15 minutes over into discussion. So the very last word is Dr. Zogby.
A question regarding the institute. How long have you been in operation? How successful?
3 years.
3 years. How successful have you been able to?
That's a great question. I would say.
And what are your major challenges?
I'd say it's so far it's been a very, very huge success and exciting opportunity because of the things we talked about, all the synergies that occur between all the different disciplines are just extraordinary. They didn't occur before. But to say, I was talking to one of our guys the other day, and he said, well, I didn't even know those cardiologists until we all came together here. Now we're, going on having a beer. And it's really an exciting thing. And that's the same thing for the university scientists. They're coming down and working with us. I at once suggested to the dean that he mandate that every scientist who gets a lab in the building has to spend 2 hours a week in a cath lab. I think that would be huge. Hasn't happened, but who knows, maybe it will.
All right. Thank you very much indeed. Appreciate all the discussion.
Thank you.